Recording going. Perfect. And with that, I'm going to turn things over to Kitty and CJ.
Thanks, Patrick. So Kitty, when we met a couple of years back, you talked about the concept of social enterprise. One definition that I've heard of social enterprise is an organization that uses business tools for social needs. Tell us a little bit about how you have set up San Diego Wellness Collaborative as a social enterprise.
Hi, everybody. Thank you, CJ, for the opportunity to talk about the San Diego Wellness Collaborative and the way we've designed our work here in San Diego to increase health equity and focus on population health by working with a broad set of partners. And so we really envision our role as the Wellness Collaborative as a place where we engage and link community and healthcare partners. We recognize that that is a unique and interesting and heavy lift in some ways, and so we focus on that. We also work very closely with the medical care community here in San Diego County. That includes private medical groups, IPAs, and federally qualified health centers in terms of making improvements to the healthcare system and the way that we operate in those healthcare teams. And then finally, we take a broad view on transforming the healthcare system as a whole to be inclusive of the social determinants of health. A little bit more is that we really, because we do our work through our partners, we really envision the work in 3 buckets of what we call initiatives. The first 2 initiatives are Be There San Diego and the San Diego Accountable Community for Health. These initiatives are focused on changes at the clinic level and changes at the upstream broad-based root cause level. We recognize that those 2 sort of ends of the stream, if you will, very upstream work and very downstream work, needed a linkage. And we envision that linkage as a community-based workforce. And that community-based workforce we thought was well suited to be served through a social services MSO. And so we recognize the value of bringing a social services MSO designed as an enterprise, a social enterprise, into the market here in San Diego, which would allow us to proceed with actually self-funding and generating revenues to then go back into our upstream and downstream investments towards health. And so you can see here where each of our projects are located across the stream, if you will, from the ACH being very upstream, where we work on root causes, down to Be There San Diego. We're working with clinical teams across the county on addressing hypertension, diabetes, cholesterol control, the things that we know can have an impact in the short term in terms of heart attacks and strokes. And then in the middle, we have the social enterprise, which both brings a new workforce to the scene and produces net revenues that then are built back into our work with the ACH and Be There.
Okay. So California has been a bellwether state in Medicaid, and CalAIM is a transformative program to improve the quality of life and health outcomes for Medi-Cal members. So what is CalAIM from a CBO or a community-based organization's perspective?
Well, what's really interesting about CalAIM, and specifically, I'm going to dig in on the community supports part of CalAIM to get started, because I think what's really innovative and interesting about this is it's taking a federal piece of the regulation called in lieu of services, which I'm sure everybody on this call is well aware of, and the state of California really saying to the plans, hey, we get in lieu of services has been confusing. And because of that confusion and that lack of clarity around in lieu of services, maybe it hasn't been implemented at scale yet. And certainly it had not been implemented to scale in California. So this was Department of Healthcare Services in California saying, we're going to go ahead and give you clarity on 14 areas that we are going to designate as in lieu of services already pre-approved as a community support. And so this created a really high level of interest from our community-based partners that we work with in the ACH, because it included things that have never been paid for by the Medicaid program before, such as meals, medically tailored meals, such as housing navigation, and not just housing navigation, but actually housing deposits that can be used to pay for those small barriers to getting into a stable housing situation, such as first and last month's rent, for example. So that was a really exciting change, and it's just started in January, and we're all trying to figure out how to bring this to life and make sure as many Medicaid members have access to these important benefits as possible. At the same time, we also have opportunity to engage very high risk, very vulnerable members in enhanced care management and provide them with additional care navigation and care coordination support.
Perfect. So what you're saying is that health plans, so now that this in lieu of services is there, health plans would need to create a network of service providers for community supports. So would a community directory service serve as a starting point for as a network of CBOs, or what else is needed for that?
Yeah, I mean, this is really an important point, that this requires a new type of network for a health plan to really have access to for their members. So we all know that health plans do a great job with having networks of physicians and ancillary service providers. And now with the community supports benefit, our health plans here also need to have a network of meal providers and housing navigation providers, folks that are able to work with these populations effectively. They know how to find the populations, engage those populations, and then deliver services in a way that's going to be meaningful to those populations. So we recognize that the CBOs are the experts in this work already. We've had housing CBOs, we have food insecurity CBOs. They've been operating for decades. And not only are they experts in this line of business, they also have the trust of their communities. They're known to their communities, and they are the ones with those deep relationships in community. So being able to create a network of those CBOs to deliver these new types of services is really going to be the best approach for any health plan to take to leverage the rich resources that already exist in these communities.
Perfect. So going along, so you're saying like a MSO of social services is something that you've spoken about.
Mm-hmm.
So health plans are already working with MSOs and IPAs, as you said, on the medical services. So how does the MSO of social service providers function? Is it similar to that? And why would CBOs want to be part of a MSO instead of working directly with the health plan?
Yeah, I think that the idea of a social services MSO is so exciting at a time like this, because it does allow for those linkages between the health plans and the CBOs to come to life, which is really the way we know we're going to be successful with deploying these new community supports. So if we, as I spoke about, if we have a network or we have a set of partners, CBOs who've been at this for a while, at decades, remember, these are organizations that have been doing their work through typically grant making processes, fundraising, and maybe getting some contracts from the local public health department or the local health and human services department, but likely not ever had a contract from a Medicaid health plan or any health plan. And so they are challenged to really think through the kind of things it takes, the financial resources, the case management and data resources, the privacy and security resources, all of those things it takes to be successful at a Medicaid health plan contract. Those are things they haven't thought about yet and may or may not have the capacity to build the infrastructure around. That's why working with a back office MSO type of social services agency can be very helpful to those CBOs that want to participate. They have the boots on the ground expertise, but don't have the capacity to build that infrastructure.
Okay, perfect. And you've also spoken about, you've told me some time back about how there could be like housing navigation service or other CBO that's already in the market, but you're able to embed community health workers that have deep expertise with Medicaid plans and then kind of enhance the service. Can you talk a little bit about that?
Yeah, I mean, I think it's important to recognize that not only are these new contracts that are available to the CBOs who've got these deep histories doing this work, it's really a new kind of workforce for them to take on. It's a workforce that's funded by Medicaid dollars to serve Medicaid members. And that does require a new workforce that does have a little bit more expertise and training in how does the healthcare system work, how to navigate healthcare services, how to have a bi-directional line of communication with the physician or the medical homes office. These are a new type of workforce that we're really building from the ground up. And I believe that this workforce, and what we've seen with our MSO services, which we call neighborhood networks, is that by housing this new workforce at the social services agency, at the housing agency, at the agency that's already been doing the food security work, we're really gaining, we're sort of hitting the ground running, working with the population of focus. And we, as the social enterprise and social services MSO, are coming in and wrapping around and giving them the health plan, Medicaid, and health care expertise that they need to be successful.
Okay, good. So let's switch gears a little bit. I mean, I know that one of the initiatives in CalAIM is also different populations of focus. And one particular primary focus has been homeless members. Just yesterday, I read, according to the CHCS, 28% of the US homeless population lives in California. These are like really hard to reach members and a universal challenge. So how have you been able to reach and engage these members?
So we work collaboratively, obviously, with all of our network partners who really are the have that boots on the ground expertise, where they are the ones who already are embedded and located in the communities and have those ongoing relationships with the populations of focus, including folks who have housing insecurity, because it's broader than just, you know, a very narrow definition of homelessness. It includes housing insecurity as well. And so with these deep relationships, we are able to leverage the deep expertise of these organizations so that our new workforce, whether it's a housing navigator or a lead case manager for the enhanced care management system, they can rely on the deep roots that are spread throughout their organizations in terms of having decades of experience with working with these populations. We support them by providing outreach support with texting campaigns, telephonic campaigns, letter campaigns, not things that are specifically very effective with the housing insecure population, but we do that work. We also work collaboratively with our health information exchange here in San Diego County, our community information exchange, where we're really digging in and looking for where is this this Medicaid member last shown up. If they're in the emergency department or in the hospital, we're working with the discharge planners and the social workers in those settings to make sure that we're uncovering where these folks are showing up and getting access through that relationship that they may be having in the emergency department, for example, to bring them into ECM, enhanced care management, or community support services.
Good. One other population that you worked with long before CalAIM is the high-risk equity members, those with complex chronic conditions. You spoke when you introduced Be There San Diego as a clinical learning collaborative. So how are some of the lessons that you learned there are being applied by your community health workers when they meet members to improve their outcomes?
Yeah, I think we have a very interesting organization in that we wear several different hats. And what the real opportunity for us is when we are able to integrate the learnings from our various initiatives. And so Be There San Diego is a clinical learning collaborative. It's been in existence since 2010. And since 2010, we have been able to do effective work with all of, I think we have about 80% of the patient population for San Diego County included in our partner organizations. And one of the things we do with our partner organizations is collect aggregate EMR data on intermediate outcomes, such as hypertension control, diabetes control, LDL levels, and or statin prescribing. With that information, we were able to publish an article back in 2018 in Health Affairs around the effectiveness of our work from the period we existed from 2010 to 2016 that showed that having this robust learning collaborative, we correlated to having a much greater decrease in heart attacks in San Diego County compared to the rest of the state during that period. So we're very proud of the work. We're very proud of our teams here in San Diego County and how hard they've worked, but not only themselves in their own systems, but coming together to form a learning collaborative and really share data, which we know isn't always a natural thing for competitive healthcare systems all operating in one market to necessarily do. But because we have access to their data across 80% of the patient lives in San Diego County, we've been able to do some really interesting work, for example, on race ethnicity disparities. And we've only been able to get this data for the past few years. And what we were able to see was that there has been an ongoing disparity between Black and white hypertension patients over time that only recently actually was closing because of the COVID emergency actually brought everybody's hypertension rates down and created a loss in what we were doing very well in San Diego County with all the efforts at about an 80% hypertension control rate. And we've lost about 5 percentage points. So that's very interesting work. And it happens in our learning collaborative, but then we wanted to apply this work to the work we were doing over with the community-based workforces and neighborhood networks. So we took all of this learning and we recognized neighborhood networks was a great place to apply this learning. And we specifically created a hypertension toolkit for our community-based workforces to use with their members that was easy to use. We distributed over 200 blood pressure cuffs to the members in neighborhood networks who had a diagnosis of hypertension. And then the community-based workforce acted in a health coaching role over the course of 6 months to work on med adherence, self-management of blood pressure, and continued just focus on increasing rates of hypertension control in the populations, ensuring that those members for neighborhood networks are getting that hypertension under control.
Good. So Kitty, one other thing, I think like a hot topic, I mean, like just switching gears one more time, hot topic around CalAIM has been referrals and creating a closed loop referral system. You just mentioned, and I know that you work in close collaboration with 211 San Diego, which is a community information exchange. So how do you identify, how does your workforce identify a need for a service, create a referral message, create a referral, and then basically manage that referral to an outcome. So how do you do that today?
Yeah, so both our ECM case managers and our community support housing navigators, and we also have other community health workers that I'll just mention really quickly that are paid for through the quality departments at health plans, specifically focused on closing care gaps. And we've co-located we have 3 of those at pediatric offices that we're co-located at. So all of these community-based workforces that we work with are integrated and have access to the community information exchange here in San Diego County. So they're able to see a full community record on their members and their clients that they're able to utilize to let them know where has these members been showing up, what services have they been accessing, and then make a warm referral to additional services as needed. The case managers between our system and other care systems in San Diego County can communicate through the CIE. And also all of that then gets documented into our case management system. So we have all of that data available as well.
So it looks like you're creating a lot of rich data. I mean, especially around social needs when you meet the members, along with behavior and also the whole engagement information that you collect as you meet the members. Do you share this data back with health plans?
Yeah, I mean, I think we're at the early stages of this part of the journey because there is a rich amount of data that we are collecting as the one having the direct relationship with these Medi-Cal members working on their social determinants of health. What we do today is we do a full initial assessment, and during that assessment, we're able to identify Z codes and document those and send that back to the health plans so that those Z codes are fully well documented and back into the health plans data systems. In addition, every time we have an interaction with one of our clients, which are the Medi-Cal health plans members, that turns into an encounter, and we actually send all those encounter codes and we can send the notes over to the health plan. If we are able to access a better contact information for the client or better information on the kinds of diagnoses that the client has, that also gets uploaded back into the health plans database as well. So I think we're in a good beginning phase, but I think there's a lot more opportunity here to grow this part of the work.
So now let's move to the heart of your social enterprise. And I think something that you're very passionate about, which is Neighborhood Navigators. So what are some profiles of your navigators? What skills do you look for and how do you train them?
So from the inception of our Neighborhood Network Social Services MSO, we always built the whole philosophical framework for neighborhood networks around the concept of having a community health worker who could serve in this role as what we branded as a neighborhood navigator. So we were really starting from that frame point of wanting community members who had deep understanding of their communities, had the historical context of their communities, have deep relationships, have cultural appropriateness and fit with the client base, and really come with lived experience. So more than anything, what's important to us for our neighborhood navigators is that they come with lived experience. That makes them, we believe, uniquely qualified to address the social, health-related needs and behavioral health needs. I put together this slide because I think that it's always interesting to see some of the growing evidence base around the impacts that adding community health workers to the system, the healthcare system, can have. And I thought this was a particularly interesting study showing the kinds of impacts adding a community health worker, which is a relatively low cost investment, can have, where you get decreases in blood sugar, decreases in diabetes distress, fewer depressive symptoms, while at the same time seeing improvements in diabetes support systems and their patients' self-understanding of their own diabetes self-management. These are amazing outcomes. We know these lead to better health. We know they lead to less heart attacks and strokes. And we also know that they, reduce unnecessary utilization of the healthcare system. So we just also believe, just to clarify, that in addition to being a CHW and coming with the lived experience, it's our responsibility to train these workforces to really be successful in working in a medical model system, which they don't always come with that expertise. So they come with the expertise on their communities and the population of focus, but they don't always know as much about the healthcare system or disease states or medication management tools. So we train them on those pieces so that they can have both sets of expertise.
So when I talk to your navigators, when I hear care plan discussions amongst your navigators, most of the member needs seem to be non-medical in nature. One of your members had their iPhone screen broken, and the navigator took it as a top priority to get it fixed. So we do talk about social determinants of health or social factors and homelessness, food insecurity, but you have told me a lot of times it's also these things like a broken iPhone screen or other things that cause the member to not even focus on their healthcare needs. Mm-hmm. So how do your navigators help uncover these non-health issues and then use that as a mechanism to get members to adhere to their health therapy or improve their health?
Yeah, I think, the health plan's goals and the physician's goals are really often quite different than the client's goals. And so it's really important that we start where the client is. And if they're struggling with food or housing or job insecurity or even a broken iPhone, we know that that's where they are at that moment. And that is where we focus our energies in building their action plan. We then utilize the relationship we can build by solving their immediate needs, which are typically what we like to call the health-related social needs, to build trust and relationship. Because a lot of what's happening in these community-based workforces is everything that happens is based on the ongoing trusted relationship, the unique trusted relationship that exists between the community health worker, or a navigator, or a housing navigator, and the client. And we're allowed, with the funding we have through the contracts, to build that relationship over time. So somebody can be enrolled in an ECM, for example, for 6 to 12 months. And that allows our navigators to have that longer term relationship, build the trust, and get to the harder issues, maybe towards the end of the 6 to 12 months, which is around maybe ED utilization. We also have the seriously mentally ill population. A lot of times with that population, they are not actively in care when we when we first enroll them. They don't remember who their psychiatrist is. They don't remember ever being diagnosed with a serious mental illness. And so those are harder conversations to get to. And so we start with some of the more immediate pressing needs that clients feel like they have. This is just an example of one of the clients that one of our navigators worked with. This woman had, a set of complex diagnoses, and at the same time was very housing insecure. Of course, that makes it extremely difficult to manage these kinds of chronic diseases, and having trouble meeting her basic needs. So what happens is we do a full assessment. That's the first step all of our navigators take, and then they turn that into an action plan, which I think the next slide here, CJ, has some of the elements of the action plan. So we know that the goal of the plan, the health plan, the goal of her doctor's office was to monitor and control her hypertension, for example. And so that's important. We know that that's a priority of the healthcare system. And we know that the dollars that fund our healthcare, our navigators, are coming from the healthcare system. That's an important goal to us as well. But we also recognize that we have to work on the more upstream social needs that she's having. So that might be something like transportation, and it might be something like food assistance. And all of those together are what's going to create a robust action plan and really make a difference in a client's life. And so you can see here the kinds of steps and interventions that our navigators would take with a client. And this is sort of a very simplistic point of view that we presented here. A lot of our clients have very complex life situations going on when we reach out to them. And so it's a lot of untangling. They also have some barriers emotionally, mentally, with their mental illnesses, to seeking help and taking care of themselves. So we work with them on that as well, do a lot of motivational interviewing, assessing for readiness for change, using techniques around communication skills, and building that personal empowerment with the clients.
Good. So Kitty, I think one other thing that when we talk about CBOs, we have this maybe a perspective that CBOs are starved for capital and technology. And you've mentioned this on multiple occasions to me, but the thing that's interesting to me is like, so how have you used technology? I know you've been you've adopted technology early in your journey. So how have you used technology to scale your operations? And how can CBOs use technology as a strategic enabler? I know it's a little chicken and egg because you're starved for capital, but how do you invest in technology? So where do you see that the trade-off in terms of when do you do it and how do you do it?
Yeah, I mean, I think most CBOs do have trouble with capital. We have access to unique kinds of capital, such as grants. And other, governmental dollars that are accessible to CBOs to oftentimes make investments in capacity building that could help us build technology platforms. I think one of the big disconnects is there is not been a move towards a standardized way of tracking client records, such as there's been with medical groups and the clinical field taking on electronic health records. So the social services sector does not have a robust, standardized way of managing client level data. They've been, the CBOs that I work with are all very interested in that and actively working on it. But it is, in their minds, a big barrier to working with the healthcare system. When they start to hear about EHRs and health information exchanges and community, they immediately start to say, oh, that's not for us. We can't get in that business. Privacy and security is another one, complying with HIPAA. So they immediately start to say, no, that's not for us. We don't operate in that kind of way. It's a real cultural difference between the way the medical system operates and the community-based organizations, whether they're housing organizations or social service or meal organizations, operate. Mainly because we all know that there's been huge federal investments in EMRs and an approach to standardizing the way we do business around EMRs. There hasn't been anything similar for social service, homeless agencies and meal agencies that would equate to the push we've had around EMRs. So I think when we're thinking about how do we really bring this bridging together between social services and healthcare organizations to really maximize the rich set of resources that exist in communities, which is inclusive of those CBOs, we really got to get smart about the way we make investments and build out that technology infrastructure. That does include things like community information exchanges. Those are a critical technology resource. In addition, each of the participating CBOs needs to have access to a client management system that probably exceeds their capacities today. So we do need to be making investments in those client management systems. And then those technology systems have to link to claim systems so that that all these CBOs can do Medi-Cal billing. Now, of course, I try to provide all this solution through our MSO services, but with all of that, we have the ability, once we start looking at data across systems, we have the ability to take a really holistic point of view and find these Medi-Cal members where they're showing up, through alerting and through robust systems, knowing that somebody's just landed in an ED, for example. That's the ideal situation where we're getting those alerts right away from the HIE. Then we're able to look into the CIE and build out and see fully where has this client been showing up over the years. We're then able to access a full set of their health-related social needs data and turn that into a set of Z codes that could go into the health plan to better analyze risk scoring and risk assessments for these clients so that we can get increasingly better at identifying the clients that would benefit from these resources. I think we're at the very early stages of even being able to find and identify the kind of Medi-Cal members that truly need these resources and then getting them enrolled.
This brings up a follow-up question. I mean, like you talked about standardization. So one is the standardization from a technology perspective, but just stepping back a bit, the whole MSO model that you spoke about, I mean, you've done this in a county. Is this again something that's replicable? I mean, that's replicable in other markets, or what do you see as some catalysts that need to be, if you were to replicate this in another market or another place, what do you see as enabling factors?
Yeah, I mean, I think what you need, I think every regional healthcare marketplace would really benefit from having something like this so that you can bring all the CBOs together into a networked approach. Otherwise, health plans have to make those one-on-one relationships with so many different providers. I mean, I think one of the unique aspects of every regional healthcare market, I'm sure this is not just true in San Diego, is that within a regional healthcare market, there's probably 500 communities. Communities get defined in different ways. And each one of those communities has a very unique set of CBOs that they are comfortable with, that have historical context in that community. I'm pretty sure health plans are not interested in going out and signing separate contracts with those various CBOs serving those various communities all over a county or a regional healthcare market. So by bringing those CBOs together, it really allows us to leverage the strengths of those deep knowledge of all of those different communities into one standardized approach. And the health plan can have one contract that would allow them to really maximize the benefit of these community relationships. And also with the networked approach, we can do a much better job of having one system that identifies all the different partners. So for example, with community supports, if we have a client enrolled in enhanced care management, we are ready and able to go ahead and refer that to the housing navigator, who's also a part of neighborhood networks. We're ready and able to refer them to the meals provider because they're already a part of our network. So those relationships are very robust and those referrals happen very quickly and very easily. There's not any friction to those referrals happening. So I think it makes the patient and the client experience a lot more satisfactory. And it also makes physician satisfaction higher because now the physicians aren't having to try to figure all of this out piecemeal. They get one source for all the solutions for the health-related social needs of their clients, which we know is a huge boon to physician satisfaction and addressing burnout. Frankly, burnout related to being unable to handle health-related social needs is a major concern of the physicians I talk to at this moment.
So circling back to where we started in terms of CalAIM itself, we are really in the first innings, I mean, early innings of CalAIM. So what do you see? I mean, like one is the community supports that's going to happen, which is like eventually roll out all the 14 of those health plans are going to do that. What do you see as, from a CBO perspective, what do you see as some of the other things over in the near term, in the next 6 to 12 months, and something in the long term? What do you see as some challenges or some things that your organization or others are focused on rolling out?
Yeah, I think one of the challenges we're having in this early phase of this rollout is really identifying the clients and being able to find those clients and enroll them. I think enrollment is low as we get started, and we need to really build out our skill sets and the way we partner across our region to really enhance the way we're enrolling folks, and then making sure that they're getting the full suite of services that should be available to them, whether it's housing navigation or meals or sobering centers or long-term support systems, that all of that becomes much more coordinated. Because it's so new right now, we don't have that coordination yet, but it's coming soon. And we have additional investments in the state of California that are being made through the health plans and directly to CBOs through both state and federal funding that will help us build out that kind of capacity that would allow us to do that. I think the other thing is making sure that these programs are financially sustainable for CBOs. This isn't always a big new line of business for CBOs. This is a small line of business for most of them compared to their other grants and contracts that they have. And so we want to make sure that it's covering the costs. Sometimes starting a new line of business can be expensive. We try to lower the cost of entry for them, but it's still expensive to just hire one or two as a one-off. And so we want to make sure that we're consolidating the services. And so we're giving each of the CBOs that are participating enough member lives to make this make sense to them financially.
Okay. And what do you see as the steps moving forward in terms of beyond the community supports? Do you see anything else or any other area of focus for yourself and other CBOs?
Yeah, so in the state of California is pursuing approval from CMS for a community health worker benefit, which would be the first time we'd have that here in the state of California, and they're targeting a July 1st start date. So we're very excited about this new opportunity for additional billing codes and additional contracts that will cover community health workers. And DHCS has been very specific in the state plan amendment that they envision these community health workers not just at clinical sites, but at CBOs that are non-clinical. And so we think this even more calls out a need for a MSO service like we provide. We're anticipating over the next 5 years growing the CHW workforce in San Diego County by 2,500, just with the new Medi-Cal reimbursement that we'll be able to access. So we're very excited about the new CHW workforce and the impacts that that can have on health equity. That's going to be a wonderful opportunity to show that we can really make a difference in health equity.
So we've kind of come to the end of most of the things that we had. So any other closing remarks that you might have? And I think like the 2,500, the CHW is a fantastic thing. Do you see any challenges in the getting the skilled workforce, or do you see any challenges around it, or any other closing comments that you might have?
Yeah, no, I mean, I think it's something to be very aware of. I think the current economic situation and the rising rates of basic needs is causing not only, hardships on our clients, but the community-based workforces that work for us and do this kind of work, they too need to have living wages, and we need to make sure that we have equity within the workforce. And so we are seeing the wages for community health workers increasing by several dollars an hour over the last several months. And we want to make sure that we are paying that living wage. So it's just something to be mindful of as we're creating sustainable workforce solutions.
Great. Any other closing comments? Anything else that you want to?
No, I'm just appreciative for the opportunity to speak with folks from all over the country about the work we've been doing here in San Diego. We're very excited and think it's a model that would benefit any regional healthcare market.
Kitty, thank you. Patrick, with that, we are ready to take questions.
Okay. There's still time to ask questions, folks, so please use the Q&A button. CJ, I did put a question in there for you. If you'd like, I can read it.
No, I'll go ahead.
Got
So
it.
Kitty, this is regarding the Clinical Learning Collaborative and the Be There San Diego. So how are you collecting this data today across the county, hospitals, and EMRs?
Oh, so with the data we collect, which is the intermediate outcome data on hypertension and diabetes control, LDL control, prescribing of statins, that data actually is provided to us because it's primary care data, is provided to us directly from our medical groups and federally qualified health centers that participate in Be There San Diego. So we have secure uploading file capacities, and we get a set of data from the EMRs up into our analytic system and do that data analysis ourselves. In terms of any kind of alerting and data that we want to be able to access for our clients to better serve our clients enrolled in neighborhood networks, we do utilize the Health Information Exchange here in San Diego. We have access to log in and be alerted and do view only of client information from the Health Information Exchange.
We have another one, Kitty. How can an ancillary provider better understand who to contract with to provide personal emergency response systems for the elderly participants in CalAIM?
Yeah, no, I mean, that's a really good question. In terms, I think the question is specifically around getting a contract with them. So one of the things to understand is that all of the CalAIM benefits are run through the Medicaid health plans. And I think you can find that list of all of the approved Medicaid health plans that have the DHCS contract on the DHCS website. They're listed there by county. And so you can see which counties are interested in providing those services in. And you'll find a list of the Medicaid health plans that serve that area. And then also that includes contact information for those health plans. So you can reach out to the health plans and discuss with them how your services could potentially meet their needs for a community supports and or ECM vendor contract. There are specific application processes that one has to go through to become an ECM or community supports vendor. So I would just reach out to your local health plans.
The next question is also a slight variant on that. So how can I get myself familiar with what each program offers? Also, if I was to do an oversight, where will I find resources to make sure the facility is providing what they are supposed to do?
So in terms of the programs that we've been discussing today, which is enhanced care management and community supports, you can actually find provider manuals on both of those programs on the Department of Healthcare Services website for California. So California Department of Healthcare Services, that website has pages that are specific to both community supports and enhanced care management. And on those pages, you will find the provider manuals, which are extremely detailed descriptions of how those programs work. So that's one answer in terms of getting more in depth on the programs themselves. In terms of doing any kind of oversight of what is actually happening on the ground today, I'm not sure there really exists. It's so new that I'm not sure there's any kind of standardized way that that's being done or published, reports that are being published at this point. And that's simply because we really only started this in January. If you were interested in learning more about how ECM and or community supports is being rolled out in your community, you would probably want to contact your your Medicaid health plan and ask them where they might be having community meetings to talk about the rollout of enhanced care management and community supports.
And we still have time for questions if anyone wants to send some in. Great questions so far. Okay, guys. All right. Well, I want to thank Kitty and CJ. That was very informative. I think you're exactly right. California is a bellwether. There are a lot of great take-home knowledge there. So I want to thank you both for that. And again, Sagitech Health is an MHPA Silver partner. We appreciate all their support they've given us at MHPA, but also our members. They've been great partners. I do want to remind everyone on June 22nd, in 2 weeks, we are going to have another webinar regarding the unwinding of the public health emergency. So that's going to be very interesting. So please join us. And again, thank you for joining us today as well. And CJ and Kitty, everyone have a great afternoon.
Thank
Thanks,
you.
Patrick. Thanks, Kitty.